Simon, the next point on the agenda is a discussion about the rest of the data. Have you got any specific comments on that? No would be fine if you don't.
Are we talking about the rest of the data within open and decision, or
X-decision, euro-cto?
I think, the data that exists within sort of stable angina PCI are pretty limited. I think we have to be open and honest with ourselves. Actually, if you look at where we have data, it's very old, and it doesn't reflect any increase in safety. It doesn't reflect any increase in patient outcomes for those who have a revascularization in stable angina at all. All that we have shown over very many years is that stable angina PCI leads to improved symptoms. It doesn't lead to improved outcomes. And why I think CTO PCI is held to a higher standard is because it's technically difficult. And the fact that you can improve a patient's symptoms and quality of life with any angioplasty is fine. We don't have mortality data pretty much for blood sugar reduction, type 2 diabetes, and COPD therapy, and a whole range of conditions. And the nonsense that we need to have mortality data for a specific therapy, I think, is unfounded, and doesn't make any sense to me. The patients who will benefit from a therapy are those who are symptomatic, and if you can make their life better, then I think that's a good place to start.
Yeah, you talk about a higher standard for CTO PCI, and we kind of shrug our shoulders and say this isn't fair, but of course in the real world there's a reason why that is the case. First of all, the cost utilization is higher, and secondly, the morbidity is probably higher as well, certainly based on open CTO. So I think it is reasonable that our threshold for intervention is carefully assessed and probably higher than in a straightforward type A lesion. I don't know, Margaret, have you got any specific thoughts?
So the other thing that always occurs to me in our institution, and I'm sure it's the same for the rest of you, is that what about EP? So radiofrequency ablation for AF, complication rates are higher than CTO PCI. The costs are not insurmountable, but there's very little in the cardiology community that questions that intervention in the way that CTO PCI is.
There are zero mortality data for that procedure, as with many things within.
On a positive note, do you mean?
Zero
improvement.
No. There's an absence of solid data on mortality.
On mortality or hard endpoints, there's nothing to suggest that ablation or pulmonary vein isolation, or in fact EP intervention for plenty of things. Okay, the heart failure arrhythmia group excluded, doesn't actually improve mortality. So why are we not holding those procedures to the same standard? I think what we understand about those procedures is that they do improve patients' quality of life in a lot of circumstances. Do we have randomized sham data to prove it? No, we do not. But yet many of these procedures are done. But if you look across medicine as an entire spectrum, that's the case for an awful lot of things. As I mentioned, COPD, type 2 diabetes, all the GI conditions. Within orthopedics, hip replacement.
I think orthopedics is a good comparator. So in preparation for this kind of conversation, I reviewed recently the large meta-analyses of mortality for hip replacement, knee replacement, spinal surgery, both decompressive and fusion procedures, as well as for various kinds of bariatric surgery, which I thought would be sort of reasonable comparators for CTO PCI. And they're all around 0.2, 0.3, 0.4% at 30 days in large sort of 10,000 plus patient meta-analyses of reports. Mortality, and that's in a spectrum of patients that are by and large younger, not hips,
unstable,
but certainly spinal surgery, bariatric surgery, and so on, considerably younger than the population we're treating with CTO PCI, and it's broadly accepted both socially and medically to accept those kinds of risks for symptom improvement.
These are patients who are absolutely stable and quote unquote otherwise healthy going into an operative procedure.
Yeah.
And there's absolutely nothing to suggest anywhere that any of those procedures will improve a patient's survival. It's purely about quality of life.
It's all about quality of life.
But if you talk about the end point in this, which is the patient, surely that's all about informed consent. That we set the expectations that, yes, this is the risk of the procedure, this is what you can expect in terms of benefit, and we don't go promising things that we can't realistically deliver. So symptom improvement is something we can realistically promise. Mortality benefit is something that we can't justify in terms of discussion with the patient.
Yes, but I mean, it's a double standard. You know, it's disingenuous to have an expectation that you should have a mortality benefit from procedure X, CTO PCI, angioplasty and stable heart disease, whatever it may be, versus something that's mainstream like a hip replacement, which does not improve mortality at all and is a pretty major operation.
No, sure. I mean, I accept the point and the point's been made, but I think that it comes from a context of us feeling that in these patients with a very high ischemic burden with a potential jeopardy, that if we design the study correct, we potentially could demonstrate that. And I think that's the context
And indeed,
of discussion.
he has treated analysis in
Decision.
in decision
Pretty much
suggested that, didn't it?
Yes, exactly. And I think that's the context of the mortality discussion, you know, but you're right. I think in terms of informed consent, we aim at what we can realistically deliver to patients.
Well, I think the confounding sort of thing within decision-cto is that if you look at the as-treated analysis and the 5-year endpoints, the absolute risk reduction for complete revasc, accepting that many of the OMT patients had a PCI for non-occlusive disease, was 7%. I mean, there's actually not a lot of stuff out there that shows that level of risk reduction. It's very interesting, and I think if you did a very large randomized trial in a sequential and well done fashion, you may well show that complete revascularization is good for a population. It's tantalizing, and it's a
It
shame.
confirms the registries that failed CTO PCI versus successful. Survival is better if you have successful long term.
Yeah.
So, but
Not a
of
fan
course
of
it's a
that
bias. Yeah.
I think I think that data is fraught with differences between the two arms, particularly when you think about who did those procedures and who did they fail in, what era were they done in. That's a very nice in the last decade of the last century and the first decade of this century, which is when those registries were done. The success-fail duality was mostly about putting people in silos of easy and difficult CTOs, patients who had easy anatomy and difficult anatomy, a lot of complexity, not much complexity, and I think that's just simply a determinative outcome that we can't control for. We have no QCA data or syntax scores on any of that.
It's absolutely right, but actually, probably it comes down to a sort of 3 group, which was difficult. No way I'm trying that. Difficult, but that looks achievable. And then easy, which was opened, and it's still about ischemia reduction. So, I mean, if you look within the context of the syntax trial, the success rate with CTO PCI was 49%, and they were supposed to open all the lesions, and I think that is something that we should reflect on. If you go to syntax 2, the success rate for CTO PCI is approaching 86%. It's not far off where recharge is, and that's something that's very, very different.
And it's worth just touching on that before we go on to Evald's presentation, but actually, even in that change between syntax 1 and syntax 2, there's been a sea change in CTO PCI, which we haven't really touched on today in terms of technical improvement and subspecialization. You know, the key point about syntax, the original syntax study, was the 49% success rate was in pre-selected patients. So those are patients in which the operator looked at the case and said,
Yeah, I can do that.
yeah, I can do that.
Yeah.
And they were wrong 50% of the time. And the big difference between syntax 1 and syntax 2 is that syntax 2 was in an era where we developed new techniques and the cases were done by CTO experts.